session. The topic is Code Orange Alert, Understanding the City's Emergency Plan and the Matrix, and we'll let the clerk get folks on the phone before we start in earnest.
Welcome to the GCI Conference Center. Thank you. Please stand by. If you are the chairperson, press the star key. Please enter your... You will now be placed into conference. There are 7 participants in the conference.
Thank you guys for joining us. The first thing we're going to do is the clerk will go through council members on the line and see who we have, make sure we have a quorum, and then we'll ask other folks to introduce themselves. Madam Clerk?
So taking roll call tonight, we have Mayor Terry and Vice Mayor McClure in the room, as well as Councilmember Baclan. On the phone, Councilmember Butts.
Yes, here.
Councilmember Osenga.
Here.
Councilmember Cease.
Here.
And Councilmember Kreitz is excused for this evening.
Thank you.
So thank you.
Just to make things easier, I know we have Attorney Holly Wells on the line. Is that correct? Okay, we'll wait for her. And then I believe we have Eric Mooring. He's the State of Alaska epidemiologist. Are you on the line, sir?
Yes, good evening. This is Dr. Eric Mooring. I am not the state epidemiologist, but I am here on behalf of the section of epidemiology.
Great, thank you so much. Sorry for the mistake on your title. I might just check and see who else is on the line.
Mayor, this is Holly Wells. I just want to make sure you can hear me. I am here.
I do hear you now. Thanks for checking on that.
Okay.
Yeah, perfect. Is there anyone else on the line?
Yes, Mayor Terry, this is Leslie Phelps, public health nurse from Kenai Peninsula.
Oh, great. Leslie, thank you for joining us also. Did I miss anyone? So just to repeat, as we entered into this is a work session. The topic is Code Orange Alert, Understanding the City's Emergency Plan and Matrix. And Eric, we'll start with you if that's all right. I know your time is very valuable.
All right, thank you, Mayor. I'm glad to be with you all remotely this evening. So I've been speaking some with the Phelps and reading some of the analyses you've put together. I don't know that I have anything in particular to present, but I'm happy to take any questions you might have. I think that the report dated 7/9, so from the end of last week, is sensible, and I agree with the kind of takeaway that we are seeing an increase in COVID cases in Alaska generally. That it seems that there has been some slowing down in sewers. Since what we've seen at the end of June and beginning of July, so that's great to see, and that you're in this kind of equivocal space where there are some positive signs, especially locally in sewers, and then some not as positive signs elsewhere, and that always makes the analysis challenging. There are no simple answers here, but if there are specific topics you want me to address, I'm happy to do so.
Dr. Mooring, this is Holly Wells. Mayor, would this be an okay time to address Dr. Mooring with a question?
Yes, please. I'll turn it over to you at this point. Thank you.
So, Dr. Mooring, I was hoping, so as council goes through this work session, one of the things they're going to be working on is marching through steps to apply those 4 metrics that the state recommended to municipalities back in April. And I was wondering if you could describe a little bit the positivity factor and the on factor, because I know the state really looks at those factors and they play a part in how they'll do their analysis on
kind of begin our analyses with broad categories, and sometimes they're referred to as metrics, but I feel like the term metrics refers to a particular number measurement. And so the categories that we look at are the epidemiology, so cases and where they're occurring, and how they're changing over time. We look at testing capacity. We look at public health capacity for contact tracing principally, though also responding to outbreaks in discrete settings like congregate living settings. And then finally we look at healthcare capacity. And within each of those four categories, they're multidimensional. So for example, with healthcare capacity, we're interested not only in hospitals, beds in general, and this is thinking at a statewide level, especially for healthcare capacity, but we're also interested in things like intensive care unit capacity. So you'll see all those different things on our dashboard, even within the healthcare capacity domain. And then I think that the epidemiology part is the most multidimensional. And we are interested in the number of cases that are identified. That's the simplest and probably the single most informative measure in some respects. But we are also interested in the trajectory over time, whether that number is going up or down. And we interpret those numbers with respect to the amount of testing going on. Because in general terms, if you're not testing, you're not finding the virus. But even testing is complicated because it's not just about how much you test, but who you test. So those are some of the big picture things that I think about, and about not just the multidimensional nature of each of these categories, but also about their interplay, particularly the interplay between testing and the epidemiology. But let me try to get now at your more specific questions about the percent positivity rate. This is reported as the number of samples that tested positive over the total number of samples tested. Usually, I think on our dashboard, we average it over a 3-day period, just to try to help deal with some of the inherent day-to-day variability. So in Alaska, even with the upswing in cases that we've seen statewide over the past few weeks.
So I might just break in and ask everyone on the phone to please mute unless they're speaking. We're hearing some background noise, and then I'll let you continue. Sorry about the interruption.
No worries. Yeah, thank you for asking that. In Alaska, our percent positivity rate, which is now between 1.5% and 2%, is much lower than most states, especially the states that are getting a lot of attention as having many, many cases and having real concerns about hospital capacity. So that percent positivity is still a bright spot. But percent positivity does need to be, at least conceptually, thought about in terms of who's getting tested. If you imagine testing thousands of people at very low risk, you're inherently going to have a lower percent positivity rate than if you really do a good job, and we want to do a good job of finding everyone even with mild symptoms and testing them. So it's not the end-all be-all. We look at trends. With percent positivity, lower is better than higher. I think I saw qualitatively how you addressed in your analysis from last week that healthcare providers in Seward, I may not get the quote exactly right, but felt that people who needed to be tested were able to get tested. And so that would be, in a kind of binary way, a fundamental question about testing that I would ask. I mean, if you have lots of people in your community, especially people who have symptoms, even mild ones, and they're saying that they, that like the lines are too long to get tested, that would be a big concern. And that would be a concern regardless of what the state's positivity rate was. So those are some of the things I think about with the positivity rate. It's most meaningful and most worrisome if a community has a very high positivity rate, and by very high, I'm referring to the sorts of rates that we're seeing in some parts of the U.S., like 15, 20, maybe even higher percentage. I think there is strong agreement among epidemiologists worldwide that positivity rates that high are worrisome. I don't know that there is strong agreement one way or the other among epidemiologists about whether a 2.5% positivity rate is meaningfully that much more worrisome than a 1.5% positivity rate. The final comment I'll make about positivity rates before moving into talking about the R value, or the effective reproductive number, is that they should be interpreted in terms of changes in testing practices. And this was a more salient factor, I would say, early on in the pandemic in Alaska, when we started to do a lot more routine testing, pre-procedure, and hospital admissions testing. That really drove up the number of people tested, and we certainly did find cases that way. So that was the good news there. But what we call the pre-test probability, in other words, just the likelihood based on the information you have before you test the person, the likelihood that they're going to come back positive. That pre-test probability is, of course, much lower for someone who doesn't have any symptoms than for someone who does have symptoms. So of course, the percent positivity rate went down when you started testing, and we collectively started testing people who were undergoing certain dental procedures or surgeries or things like that. And that doesn't necessarily mean that factor alone doesn't mean the epidemic got better. Now, in the long run, identifying more cases is a part of controlling this epidemic. So in that sense, it helps. But changes in the percent positivity need to be interpreted in changes in the testing practices. The last big change in testing practices we had in Alaska was now about a month ago, or even more than a month ago, with more traveler testing. So over the past few weeks, I would say our general testing practices have been relatively stable, so probably don't contribute to changing our case counts or percent positivity as much as they might have at certain points earlier on. Do you want me to stop here and we can talk about percent positivity, or do you want me to move into talking about R? Dave?
I think I'll let council weigh in. My hope, this is Holly, by the way, my hope is to, as we walk through the metrics, just ensure that council really understands some of these concepts, because this may be, this may not be the first or last time they look at corridors and they look at the proper next steps. So by understanding some of those factors, I'm hoping it gives them the tools they need over the life of COVID as they try to govern through it. So if they don't have any questions on positivity, I think going into the R factor would be great. But Mayor, can we just check in with you and see?
Yep, does anyone have any questions? I'm ready to move on. Okay, thank you.
All right, thank you, Mayor. So talking about the effective, R, it is often written as a capital letter R, either referred to as R0 or R0, or you might see it RT or R effective. Subtle nuances to all of these, but I will try to talk through a little bit. But the big thing is that this is an average measure of how many people we think the typical infectious individual infects and causes to be infectious in turn. And oftentimes in infectious disease epidemiology, this is presented as a general property of a disease. And the kind of way it's often talked about is in a completely susceptible population. So a population with no immunity to the disease and no control measures in place. If you introduce a case of that disease into the population and you get chains of transmission going, on average, each infected person is going to infect how many additional people. And so for a disease like measles, are the effective, the basic reproductive number, the term basic kind of refers to what you have community. The basic reproductive number is something between 10 and 20, is very high. For most viral respiratory diseases that spread primarily by droplets instead of through true aerosols that hang in the air, you're looking at numbers more around somewhere between 1 and 3 to 5. These values vary a lot, and the estimates vary a lot. And one of the reasons they vary a lot is because it's not truly just a property of the disease, it's a property of the disease in a given community. And depending on how much people interact with each other in a community, it might be much easier just inherently for a disease to spread or not spread. If it's a disease that spreads particularly among children, for example, and you're a community with lots of young kids, then it's going to, on average, spread more easily than if you were a community that, on average, has more older people. So there's lots of community-specific differences that can lead to differences in the average number of people that each infected person goes on to infect. And because it can change, it can vary from place to place, the other key thing, and this is really what gets to the heart of what a lot of people try to look at with COVID, though I'll emphasize the try part because it's hard to do for some reasons I can talk about. But we want to know how this average is changing over time. We think that, generally speaking, in communities that don't know they have COVID spreading, or the virus that causes COVID spreading, the reproductive number is somewhere between 2 and 3. There are credible estimates that are significantly higher than that, actually, but most researchers have come up with something in the 2 or 3-ish range, which means that when people aren't doing anything, social distancing, mask wearing, extra hand washing, when people aren't doing any of those additional things, we often see that the typical person with COVID is going to infect 2 or 3 other people. But of course, we know we have COVID in our community, and people are taking action both on their own accord and because leaders like all of you are encouraging people to take action, and so that changes how much the disease, how readily the disease is spreading. And hopefully you can get to a point where the average person who's infected is infecting 1 or fewer other people. And if that's the case, if the effective reproductive number is less than 1, then that means that the disease is actually not going to be able to persist. That it'll spread a little bit, but because on average it's not able to replicate itself, it will eventually die out. But even if you can't get the effective reproductive number below 1, even if the average person is still infecting more than one other person, lower is still better. You know, an effective reproductive number of 1.3 is much more slowly spreading, much more manageable for our healthcare system and for our public health system than it is if the effective reproductive number was 2.5 or 3.5. So the key kind of point to take away from that is conceptually that even if you can't stop this, slowing it down is still a valuable accomplishment, especially as far as healthcare capacity goes. Find time to build up that healthcare capacity. So that's my kind of general textbook background on the effective reproductive number. I think for many communities in Alaska, including Seward, the effective reproductive number itself is probably not a very helpful metric, and which is unfortunate because conceptually it seems really useful. But one of the challenges with the effective reproductive number is that it is all about averages. It's about what we expect to happen on average. But we know that when dealing with real life situations in a particular time and place, like in your community, we care as much or more about what has actually happened or might happen rather than just one average of what we expect. So the challenge with all infectious diseases, but I would say especially with COVID, is that some people infect a lot more people than others. And this idea of just the average effective reproductive number doesn't really capture it. And I think actually what happened in Seward over the past few weeks is a very good example of this, if you will, insofar as in some of the way it was possible for a community to go from having effectively no cases to having a few dozen cases in, what was it, a week or 2 week period, is that there were probably a few events in group settings where people were gathered in which more than just one person was infecting 2 other people. You maybe had some events where one person was infecting a bunch of people. And it's really hard for us to know specifically in Seward what those numbers were, but given the kind of sudden spike you saw, I think that's most likely what was going on, and the effective reproductive number doesn't really capture it. Unfortunately, we can only confidently estimate effective reproductive numbers in hindsight after we've looked at all the data and we've had a chance to detect the cases and the people who've been infected. There's a lot of academic work going on about how to best estimate these effective reproductive numbers given the partial data that we've collected real time. But it's a big challenge. We do calculate an effective reproductive number for all of Alaska as a whole, and it's a sort of simple measure of our trajectory. Right now, our effective reproductive number, based on some ways of estimating it, but other methods of estimation, I'm sure would lead you to a different conclusion in terms of the exact number. But overall, we're estimating a number between 1 and 1.5, which means we're definitely seeing an increase that the average person is infecting more than one additional person. So that's why you're getting that growth. But we are, at least as of right now, we're not estimating the sort of number like 2 or 2.5, which is reassuring because it's in line with what we would expect with efforts being made around social distancing and mask wearing, but certainly not a full hunker down. We know that in early March, at least in Anchorage, we did have, and well, throughout, we've actually, at least since early March, we've had sustained community transmission in Anchorage, just at different levels up and down. It would be great if I could tell you, and if we had an estimate for the effective reproductive number in Alaska in March, early March, before we really knew how much COVID was here. But unfortunately, I can't give you an estimate for that, and the reason is because we were really ramping up testing as the state and Anchorage were going into the hunker down phase. So the probability that cases were getting detected went from hardly anything if you're not testing to much higher in a matter of a few weeks as we think the epidemiology was changing. So basically these two things are kind of hopelessly confused. We know for sure that the effective reproductive number in Anchorage and elsewhere in Alaska must have been greater than 1 because we had community transmission, and if you don't have an effective reproductive number greater than 1, you by definition can't have community transmission. But I really can't tell you if kind of the baseline transmission in Alaskan communities is an effective reproductive number of 1.5 or 3. It really could be anywhere in between. That's maybe all sort of beside the point now because we are doing things to try to control COVID. So that's going to keep it lower than whatever it was back in March.
Great.
I think for small communities, it's the dynamics of COVID in small communities, and by small communities I mean, let's say anywhere with fewer than 20,000 people roughly, so I would include Seward in this. The dynamics of COVID in communities like that are probably going to be driven by what you saw in late June, early July, where you had periods of explosive growth, and then in part because of public health measures and also probably because of the inherent randomness in infectious diseases, it did not continue to be quite as intense. And also because people's behavior changes. This is part of the public health measures. People have agency and change their behavior in light of the information they learn. So I think that the effective reproductive number is unfortunately ill-suited for capturing the short but explosive kind of outbreak dynamic. It's much better suited to large, densely populated urban areas where you have a lot of transmission and the randomness just averages out. I know that was a long answer. I hope that
was wonderful. Thank you. This is Holly Wells again. I think if council doesn't have any questions, I think we'll move on to the analysis now that we have those pieces for the epidemiology. And Dr. Mooring, thank you, and Ms. Phelps, thank you for arranging this. I think it's really helpful, and we know your time is very valuable.
Oh, you're welcome. Glad to be here, and if you want me to, I'm happy to listen into additional discussion and take any questions that might come up, but otherwise, yeah, thank you, and always happy to come back for further discussion as well.
Wonderful. Yes, that would be great. We certainly would love to have you on the line. And really, the conversation now, we're going to move into sort of the macro, taking a look at the City of Seward's recovery plan, the way they adapted the metrics that the state recommended, and just really starting to understand how that conversation takes place. And I think, Mayor, if it's okay with you, I'll just run through those really quick.
Yes, please. That sounds good. And then Leslie, if you want to speak up or have something to say, we thank you for being on the line too, and feel free to chime in.
Yeah, thanks, Mayor. I appreciate that. I guess the only thing that I would add, I happen to be sitting and listening in on the governor's presentation tonight, I don't know if anybody else was also listening in on that, and they talked too about hospitalization rates, but again, they were state data, not so much individual community data, and just mentioned how the rates for hospitalization are so much better in the state of Alaska. So it's hard to make any decisions just based on, like Dr. Moore said, sort of one rate or one measurement. So thank you very much. I appreciate listening in on your conversation, Mayor.
Great, thank you. So Holly, we'll have you start through the matrix if you would.
Okay, so just as a quick review, as council knows, under your recovery plan, in the event you have a rapid increase in COVID cases, you look at certain metrics to determine whether or not declaring a code orange, which has certain consequences, which we'll talk about, is necessary, or if there are ways to regulate more specific to the actual outbreak that makes sense, and then council can go down that road. So the first step really is you obviously have the rapid increase, and we recognize that, and then you go through the metrics. And the metrics include epidemiology, testing, public health capacity, and healthcare capacity, which Dr. Moore did a great job of summarizing. And really the state's metrics are the same ones we're applying, so there's no reason for me to repeat that. What I do want to talk about is the epidemiology for the event that we are looking at, which was around June 29th, we saw a rapid increase in cases going from 3 or 4 to approximately 16 in a short amount of days, and that really put the medical team on notice, and they started paying attention to the numbers. They started looking at both the epidemiology, which is the trends and forecasts of COVID in Seward, as well as these other pieces, such as what the testing capacity is in Seward and the public health capacity on the ground in Seward, as well as the healthcare capacity. So if everybody has the report that your city manager submitted, you will see a much more detailed rundown of each of those. But the important part of this work session is to make sure everybody is comfortable going through this analysis, and that the public is very aware that there is an analysis, that it involves leaning on the state epidemiology team, because they do keep a very good record of what's going on in the state, and they give us a lot of guidance on where the local medical team should be going, but also looking at our numbers and leaning on our medical team members who have a really good understanding of what our bed capacity is and why, and are very sensitive to any change in those capacities. So I don't know if it would be useful to go through the numbers in that, regarding the number of recorded cases in the assessment period, or if that is something that I think council feels comfortable with, I'll just allow you to rely on the documents for that. But if you would like me to walk through specific data, I can do that as well. I'll ask what the will of the council is on that.
Well, I think at this point, let's just have you move forward with the generalities, unless there's anyone specifically that wants to crunch the numbers again. It is all written in this memo.
Okay, so what I will say is what was especially alarming when we look at epidemiology, and I feel a little awkward because I'm speaking for the medical team here, but this was after a lot of discussions with them regarding these numbers on behalf of your incident commander. So we had 27 new resident cases in Kenai, and we had 21 in Seward over an assessment period. And that rise put Seward as the third largest number of resident cases during that period. When you are with Wasilla tied with Seward. And so I think that really made it clear that given the size of the population, we had a very real issue. At that point, when we looked at the cases, we started looking at what's going to happen with these cases. And what the medical team was looking at is where are these cases being contracted, how are they being transmitted, what's the risk of there being more cases out there or undiagnosed cases. And so when they go through that, they look at what other pieces they have for the metric. Do they have testing capacity? And I think I get the impression from the medical team, as well as your incident commander, the testing capacity is actually very good in Seward. And there is a lot of, there's a lot of confidence in the ability to not only test but get results. And while the results have been coming in a bit slower, so they used to be around 24 to 48 hours, now they're moving a little closer to 72 hours. That turnaround is still allowing the medical team to, and the state of Alaska, to contact trace and figure out where those positives are coming from and how we isolate and create social distancing and quarantine measures specific to positive cases, which is ideal. So the next issue, so they look at that, and when they look at those epidemiology numbers, they're also looking at positivity rate, and there's this R factor component. So those terms are important to understand because they may come into the medical team's assessment depending on what the situation is, right? Each situation will be different. The public health capacity, that's an important one because I think this is one you can look at in two ways. You could look at the public health capacity as, you can look at it on a statewide level and contact tracing and individuals coming into the city of Seward. And you can look at it as on the ground positive cases in Seward and tracing the contacts there. And it's a very different analysis, or could be, depending on the state's capacity for contact tracing and their ability to follow up on a positive case very quickly. And right now, Ms. Phelps addressed this when talking to the incident commander and the medical team, and I think there's, in Seward, both on the state level and the local level, that contact tracing is working well, and so that criteria is healthy, I mean, relatively speaking. The next issue we look at is the healthcare capacity, and when we look at that, Seward also has one of those odd situations where you could look at healthcare capacity and say, Seward's healthcare capacity is endless because it transfers patients to Anchorage. So its ability to care for them within the city of Seward is not really a good measure of its ability to care for COVID-positive patients. At the same time, I think one of the things the medical team really explained well to the incident command team was we may be transferring every patient who has a serious illness or a serious COVID-19 infection to Anchorage, but in order to do that, there's often care first in Seward, and when we take care of a COVID-19 positive patient in Seward, they effectively take up 2 of 4 beds, because we cannot put a patient who is a non-COVID patient in the same room as the person who has COVID. And so this is in the report, but I think it's an important thing for the public to understand. So when the medical team looks at what is our public health capacity, they look at the ability, they look at it as Seward has a health capacity of 1. And they also look at the state of Alaska's healthcare capacity so that they know what their transportation options are. So every time that there is a rapid increase in the rates of COVID, you can expect your medical team with your incident commander to go through each of these factors and to provide a report, whether it's verbal or written, to council as quickly as they can. And when I say as quickly as they can, there is so much going on and they are working so hard to actually combat the illness on the ground that collecting the data and analyzing the data takes time. But this metric ensures that when council makes decisions that have significant economic impacts as well as public health and safety impacts, that there is a standard, a guideline, something that the public is aware of, something that people can weigh in on, disagree with, or rally behind, whatever it is, but there's transparency and it's clear that there is, where it's not as reactive or as emotional as we may see in some communities throughout the country. So I'm going to pause there and ask if there's any questions, and then I'll move briefly on. I have about a 10-minute spiel on Code Orange, and that will, I think, leave 5 minutes for additional questions.
That sounds
Is there
good.
any questions on the metric system?
I don't see any in the room and I don't hear any on the phone, so we'll have you go through Code Orange.
All right, moving right along. Okay, and one thing I will say, I know that this is difficult and that we're throwing a lot of very micro concepts at council, and there may be concern as to why you need to know the metrics on this level and get this involved in the nitty-gritty. But I think the reason why is when the medical team makes recommendations, for example, they recently made a recommendation fully unanimously requesting Code Orange, to the extent council has to weigh that recommendation against other things, it's really important to understand every aspect of what underlies their recommendations. So I hope that that's helpful, and I know it is frustrating, so just bear with me and we'll get through this next part very quickly. So the next, so in your report, your city manager does not recommend Code Orange at this time, and he says it's warranted, which I think if you look at the metrics, and that is very appropriate, but I think the city manager recognizes that with all of the social distancing measures you put in place right after the rapid increase and the reduction in cases, the change we see in the data, council has, it would be appropriate, let's put it that way, it would be appropriate for council either to declare Code Orange or to continue watching and paying attention to the metrics because public health and safety is preserved under either approach, at least so far as we know now. So that is the report. To the extent council decides that they want to see this on another agenda and wants to take up Code Orange, that should be a discussion you have with your incident commander. But I think without that discussion, they continue to watch and wait, and no Code Orange is planned, no declaration of Code Orange is planned by your incident commander that I know of in the immediate future. So what is Code Orange? I think the community sees Code Orange as when things get really bad, the city is going to lock us down. And while there are certainly elements of truth to that, what Code Orange does is when the metrics align, when there is a issue and things get really bad, the city steps back into what the state had put in place under its hunker down order. So that was back in the end of March and early April. And what that means is all of the individuals are required to go to and from their places of work, if those workplaces are essential businesses, and they can exercise and go outside, and they can go to the grocery store and hardware stores, but socialization and the way that we come to expect in the summer, which is gatherings and barbecues and going on tours and ecotourism and wildlife exploration, that halts. So if a 10-day Code Orange is declared, individuals will be able to go to their jobs, which include healthcare, public works construction, housing construction, utilities, banks, law enforcement, of course, and government, but also all fishing and processing endeavors, plumbers, electricians, and tradesmen continue to operate. Auto and bike repair is open for business. Child care facilities are open to the extent they serve individuals who are employed as essential workers or members of the critical workforce. So in your packet, you have a couple handouts that try to make this really easy to digest and ensure that people know what Code Orange is, so they understand that it's not a full lockdown, but it certainly is a sacrifice, and it certainly is a very serious step that council will consider very closely, but it doesn't have the ramifications that maybe some expected. And so I do encourage and I know council's very familiar with this, but also the public, to review the House Mandate 11, which is part of and posted with your recovery plan. So that's really all I have. I just want to make sure council feels very comfortable and has a comprehensive understanding of the recovery plan process both for this particular outbreak and in the future. Is there any questions or any thoughts?
Craig Ambrosiani, he's the director at the CHC. He's going to ask a question.
Or actually, I was going to add.
Oh, yeah, thank you. Yes, comment.
I didn't hear it in there, but what changed the course of this outbreak, I think, was the voluntary actions of the downtown businesses, the bars and the restaurants. If they had stayed open and not taken the actions they did, I think we would have had to go to Code Orange. But I honestly think they prevented it because they took it upon themselves to shut down without anyone telling them they had to. So I really do think that if there's going to be some kind of report, that needs to be mentioned because they had a big impact.
Do you think it was such an impact that right now they're at 50% capacity under the current mandate? Do you think that changed the trajectory of that so much that should continue? Do you think that the 100% capacity was part of the issue, or do you think, like, what's the story behind all of that then?
I just think that they had, we know they had a concert, and that is where it started. They immediately backed off and reacted.
And reacted quickly.
On all our behalf.
Mm-hmm.
We didn't predict that when we made our recommendation as healthcare advisors. So it was just a good outcome. I don't know if it was because of the 100%. I think the 50% is fine, but I'm not sure what the economic impact of that is.
Okay. Do you have any further comments about concerts?
I think large gatherings in small places
Yeah.
should be stopped.
Okay.
Yeah.
Thank you. Are there any comments or questions from council members on the phone? Any? I have a question, Holly. If we went to Code Orange and the schools are in session, how would it affect the schools?
I think the schools would continue to, because if the schools are called into session by the district, or if the state addresses schools too, assuming the borough opens the schools, I think we would consider those an essential business, and we would consider the entire school structure to be protected under the statutory authority that is created for schools to really govern themselves in a lot of ways. So schools would be open. Any Code Orange wouldn't impact that. Kids would go to school and come home.
Okay.
It would impact their activities afterwards, though.
And then we do have a list of the businesses that would be open. Do you have just a number of examples of businesses that would close? It would be restaurants doing takeout only. Would bars be opened or closed?
So bars would be closed. A lot of services would be closed, such as tattoo parlors or the hairstylists and salons. That was a very difficult period for them when we were closed, because there's really no way to keep the social distancing requirements. So all businesses that serve less than 10 people and can maintain social distancing are seen as essential businesses under the former mandate and under our community outbreak rule. But again, any business that can't really maintain that social distancing is going to be impacted. I think the big ones, though, are bars, restaurants losing dine-in capabilities, and hairstylists and services such as that.
What would you look at, like charter businesses?
That question was actually asked of the state early on, back when the House continue to operate, but they made some recommendations regarding taking out only one household or group at a time, and also maintaining 6 feet of distance, which is difficult, right, on a charter to maintain that distance. So in the event that I would take the position, and we have in the frequently asked questions, to allow charters to function and maintain social distancing. But to the extent the reality of that is harder than the legal directive, if it doesn't work in real life, we would have to adapt to that.
And I think that's good. I don't know if anyone else has any questions. I know we don't have a lot of time. Okay, well, hopefully we will not have to go through the Code Orange matrix, and we can, again, like Mr. Braziani said, if there's a flare-up in a specific industry, that they're able to respond quickly, and we're able to also put in potential mandates to protect the rest of the community. Are there any other comments?
Absolutely.
Oh, yeah.
And Mayor, I think one really important thing to note too is now that you have been through this consideration process, and now that the city manager, as incident commander, has worked with the medical team to draft a report, and all those pieces are in place, I sincerely hope Seward never has to consider a code orange, and that we continue to see the decrease. But if that is not the case, you have the tools, and I think they're fine-tuned and ready to go, and your community has been through the process, and it should be hopefully as smooth as it can be consideration.
Great. Vice Mayor?
And Leslie with Public Health, just one last thing, Dr. Mooring and I were talking about, I don't know if he's still on the line, I don't know if he needs to be, but the other thing to take into account with this is if you go to Code Orange, this isn't like a forever type of thing, and so you could also look at maybe writing up something that when would we discontinue this? It may very well be, as COVID goes on and on, that you go into Code Orange for a period of time, say one incubation period, 14 days, or until you start seeing cases drop off. So you may want to define that as well, and that gives you a little bit of freedom to not feel like you're just kind of locking everybody down for extended periods.
Yeah, I believe we do. Thank you. That's a good point. We do have that as part of what we would do, whether it's for a week or 2 weeks. And I know that there were lots of, we have one public comment we don't have time to read because we didn't specifically ask for public comments for this, but we did have a lot of input from businesses that even closing down for a week would be problematic and put them out of business. So we are well aware that there are some short-term options around that. So we'll go ahead and we'll adjourn. Thank you.